So biomarkers really refer to any measure that tells us about the presence of a disease or the state of pathology. So it's not a clinical outcome measure. It's something else that tells us about the state of the brain and ongoing disease, which may be otherwise difficult to identify. And you might want these to determine the diagnosis, quite common indication biomarkers. More interesting, I think, is about understanding what biomarkers tell us about the prognosis. So if I measure something now, what does it tell me about this patient's future? And that also feeds into how you can use biomarkers to increase the power and effectiveness of clinical trials by stratifying or segregating patients who maybe have, for example, a positive biomarker patient might go into the trial and a negative biomarker might be kept out of a trial because of likely efficacy. So biomarkers have many different purposes, and one of the really exciting things, and one of the things I really try and make clear in the talk, is about how you can try and choose the right biomarker for your particular study purposes. Because biomarkers have different purposes, and so one biomarker might be good for one purpose or not so good for another purpose, I talk a lot about the principles as to how would you choose your biomarker, what might you want. So it's not, I'm not trying to argue that this blood test or that scan is always better or worse. It's more about the choices you have to make. When might it be useful to use a PET scan, an MR scan, cognition, a blood test, or spinal fluid? There's different sorts of biomarker choices we have. When do you need it? In terms of movement disorders, and particularly the so-called family of tauopathy illnesses, so progressive supranuclear palsy, corticobasal degeneration, and the overlap with frontotemporal dementia, biomarkers are particularly powerful to both understand the disease and to increase the power of clinical trials. But you need to think, which one do I need? So I introduce a way that you might assess the quality of evidence for a given biomarker. Is this biomarker good in the early stage of diseases? Is it very specific to a particular type or variant of your illness? Does it track your illness over time? These are the sort of ways you might want to evaluate your biomarkers, and we discussed that, a formal biomarker utility system, we call it. And then I lead through some different examples about how biomarkers can distinguish the diagnosis, predict the outcome of patients. For example, what can you take in an early stage of PSP, for example, measuring the degree of inflammation, and use that to say that this patient is going to move very rapidly in their illness, whereas another patient may have a very stable phenotype, a stable course of their disease. And I illustrate this using a variety of PET ligands and MRI and cognition. One of the things that's really needed in the field is not that each group fights for its own biomarker and says, we show this biomarker is useful and another group shows another biomarker is useful. What's really needed is that both groups, or in fact all groups, work together and we can compare biomarkers head to head. So in the same group of patients and volunteers, we can study all these different biomarkers alongside each other. And that's one of the things that the Prospect study in the UK has been doing, is to really compare simultaneously all these biomarkers for different purposes of diagnosis, prognosis in a longitudinal design. And with that head-to-head information, again, it's not about saying which biomarker is generally best, it's about which biomarker is most suitable at any given stage of disease or for a particular type of clinical trial or for a particular type of diagnostics. So, and that's really one of the things I end in the talk, is emphasizing the need for collaborative research to compare biomarkers head to head and indeed to combine them. Sometimes there's value in combining two different measures. And increasingly we wanted to know not just about what does my patient have now, I might call it a diagnosis, and simply what variant they have now, but what about their future, what about their prognosis? And that really needs longitudinal studies to understand the different roles of biomarkers longitudinally for stratification and prognostication or prediction in clinical trials. One of the things I want to bring out again in the talk is I don't focus just on one particular disease at a time. So these aren't issues that are just for PSP or just for corticobasal degeneration, or not even just for Parkinson's disease. And one of the reasons for that is although we're taught in our textbooks, in our medical training, that these are different diseases, actually the truth is they're much more blurred. So there's some similarities in the underlying pathology. They might have different proteins, α-synuclein versus tau, but downstream in the pathogenesis of disease, there's convergence on some similarities. It's no surprise that these often get called together under the group of movement disorders or mixed cognitive movement disorders, because there's convergence in the neural systems that are affected and the biology lead underlying symptoms. And if you look closely at patients and you do formal tests of the similarity in symptoms and signs, what you see is that clusters of signs do fit together that look like one's classical phenotypes. So a gaze palsy with falls and axial rigidity is a classic clustering of symptoms that would point towards progressive supranuclear palsy. But actually, if you look at those symptoms and signs, they are also found commonly in other disorders that might present looking more like corticobasal syndrome or more like frontotemporal dementia. Or conversely, patients with frontotemporal dementia, if you follow them over time, will often then develop a gaze palsy and falls. So at the population level, you can find examples of the classic phenotypes. But the more you look and the longer you follow patients over time, the more you see overlap and convergence. And I think it's then best to recognize that, to celebrate that diversity of patients, and to use it to understand the biology and treatment opportunities. So we start talking about what is termed a transdiagnostic approach, both to understand the disease, but also a transdiagnostic approach to treat the disorders. So if, for example, we have biomarkers of the pathology, of indicating the presence of pathology that particularly relates, for example, to apathy, as one example, a symptom that's very common in all of these different diseases, where you had a treatment that might be directed to apathy, you would want to apply that to all of the different disorders where apathy is expressed and where you see the underlying biology of that apathy, regardless of the diagnostic label. So it doesn't matter if it's disease A, B, or C. If the biology is there and it's driving those symptoms, that is what you would want to treat. So another aspect of the field that I think we'll see developing more and more over the next couple of years is this reference to transdiagnostic treatments. Now, it does recognize patients differ one from another, certainly, but being too bound by classical diagnostic labels is becoming very unhelpful if you actually want to reach out and treat effectively the highest number of patients.